Welcome to the Open Classroom panel discussion on Medicaid at-risk data, stories, and strategies to protect access. I'm Stephanie Anderson with the Clark Fox Policy Institute here at the Brown School at Washington University in St. Louis, and I am very honored to introduce a host of panelists that we will have joining us today for this important discussion. I want to recognize our panelists briefly, and then we'll do a little housekeeping and hand it over them to take it away. Joining us today, we have Amy Bluen, the CEO and president of the Missouri Budget Project, Earlene K. Bolton, senior outreach coordinator at Legal Services of Eastern Missouri, Sheldon Weisgrau, vice president of health policy and advocacy at the Missouri Foundation for Health, and Dr. Tim McBride, the Bernard Becker professor and co-director of the Center for Advancing Health Services Policy and Economics Research at the School of Public Health at WashU. We also have our moderator joining us today, Robert Gibson, the Director of Policy and Advocacy at the Community Health Commission of Missouri. And we'll also be joined by Asia Wilson, who will be helping us with, who's the Advocacy Mobilization Manager at the Community Health Commission. And will be helping us with the Q&A today. And then before I turn it over to our leader to sort of kick us off today, I want to just mention briefly that we are recording this, and if you have questions, you can post those in the chat, and the panelists will have time for Q&A at the end of the session. So I'd like to introduce Risa Rollins, the CEO of the Community Health Commission of Missouri, to get us started. Thank you.
Thank you. Good afternoon, everyone. So excited to be in space with you today. And thank you. Thank you so much for joining us for this urgent and timely conversation on the future of Medicaid in Missouri and across our country. I want to especially thank those who took the time from wherever you are across the state and all that is moving across our state to take time for this really important conversation. For us at the Community Health Commission, why does it matter? Like, this is the very foundation. Our fight is rooted in equitable access to care. Medicaid is at the heart of that fight for equitable access to care. It's more than just a line item in a state budget. We live and breathe the critical importance for those of us who have at some point accessed the system, those of us who have helped folks access the system, and those who are providing services within the Medicaid system. It's the backbone of care for children, for older adults, for low-wage workers, for people with disabilities, and so many others who deserve to live with dignity and access to the care that we all need and that we consider to be a right, not a privilege. We're proud to partner with the Brown School at Washington University, my alma mater, and grateful for their commitment to advancing the dialogue that connects research, lived experience, and policy. We're also deeply appreciative of the Missouri Foundation for Health, the Missouri Budget Project, and the Medicaid Defense Collaborative, and all of the folks who have stepped up to say now is the time, and whatever resources, relationships that we have, we're going to put them to full use in collaborative partnership to ensure that those who are most vulnerable among us within our state have access to the care that they deserve. We're thanking to Legal Services in Missouri as well. So everyone who's taken the time out to participate off-screen, on-screen, in person, behind a pen, in every way behind this effort. So today's panel will explore that intersection of equity, access, and community voice in helping to shape Medicaid policy. We'll hear from experts, and I'm really excited to be among this panel of experts who will bring data, lived experience, and actionable strategies to life that help us not just talk about what the issue is, but think about what are our next steps and how do we stand together to advance and protect Medicaid. And then we'll open the space for your questions, for your reflections, and for ways to get involved. So at this time, I want to move myself from the space. I'm excited for the conversation. I'm really honored to introduce our moderator, Robert Gibson, our Policy and Advocacy Director here at the Community Health Commission of Missouri, and he will guide us in today's panel discussion. Rob, take it away.
Thank you, Risa. Truly appreciate the intro, and thank you again for the warm greeting. And we also want to give a special shout out to you. I know you just celebrated a birthday this week, so happy belated birthday, Risa. Uh, Thank you again for your leadership and your fearless advocacy, especially as it pertains to Medicaid. And so with that being said, I want to thank all of our attendees and community members for being here today, making time in your schedule. We truly appreciate you being here and participating in the great discussion we're going to have today. And with that, I want to introduce our panelists and give you a little bit more background about them. You already heard who our panelists are, but I get the pleasure of giving you a little bit more information about who they are and the work that they do. So we're going to start with Amy Bluin. Amy Bluin founded the Missouri Budget Project in 2003 and serves as its president and CEO. Amy has a master's of social work from St. Louis University and a bachelor's of arts in political science and religious studies from Loras College, and that's located in Dubuque, Iowa. Is that correct? Dubuque. Did I get that right? If I didn't, I apologize.
Dubuque, it's okay.
Dubuque. Okay. Please forgive me, anyone from Dubuque. Don't come after me later. Amy previously served as a director of advocacy for Catholic Charities of the Archdiocese of St. Louis and as government relations staff for the United Way of Greater St. Louis. She's also served as an adjunct professor at St. Louis University, spent time working in Central America and with the Iowa Department of Economic Development. In 2012, the St. Louis Business Journal named Amy one of the most influential St. Louisians. Other awards include a 40 Under 40 award from the St. Louis Business Journal and the Missouri Women's Network 2010 award for advancing women's equality. So we are excited to have you here today, Amy. Thank you. Next, I would like to introduce you to Earlene Bolton. Earlene was born and raised in St. Louis, Missouri, with over 16 years of dedicated experience in social services and advocacy for underserved populations. Earlene Bolton is a seasoned professional committed to making a difference. Earlene holds a Master's of Health Administration and a Master's of Arts in Nonprofit Leadership from Webster University, along with certificates in diversity, equity, and inclusion and ethical leadership from the University of South Florida. Earlene is also a fellow of the Racial Justice Institute. Currently, as the Senior Outreach Coordinator for Connecting Kids to Coverage program at Legal Services of Eastern Missouri, Earlene collaborates with school district staff and community partners to enhance healthcare access for families and children. Her work includes addressing systemic issues such as enabling unaccompanied youth to apply for Medicaid independently, resulting in significant revision of state Medicaid policy. Earlene's leadership extends to training and providing technical assistance on the Missouri HealthNet application, and she serves as the project coordinator for the Medicaid Storytelling Project, capturing the lived experiences of Missouri's Medicaid consumers. Her expertise and dedication have earned her appointments to the Cover Missouri Steering Committee, Black Men's Health Campaign, and Generate Health Advocacy and Advisory Committee. So thank you so much, Earlene, for being here today, and we are excited to hear from you. Next, I will introduce you to Timothy McBride. Timothy McBride is an influential health policy analyst and leading health economist, shaping the national agenda in health insurance, health reform, rural health care, Medicare, and Medicaid policy. He serves as co-director of the Center for Advancing Health Services, Policy, and Economics Research at WashU and heads the Rural Health Policy Lab for the center. In addition to several dozen scholarly publications, he produced the book Transdisciplinary Public Health: Education, Research, and Practice, co-edited with Deborah Hare Josa, as well as a collection of reports, white papers, and other policy products that have had an important impact on the national policy debate. Tim serves as a member of several national committees and boards, including the Midwest Comparative Effectiveness Public Advisory Council for the Institute for Clinical and Economic Review and the St. Louis County Justice Services Board. He is past chair of the State of Missouri's Mo HealthNet Oversight Committee, which advises the state's Medicaid program. We're excited to have Tim here. Thank you for being here, Tim.
Thanks, Robert.
You're welcome. And last but certainly not least, I would like to introduce you to further Sheldon Wisegrove. Sheldon brings 4 decades of experience to his position leading the Missouri Foundations for Health health policy, advocacy, and government affairs functions. In his role, he directs work focused on eliminating health inequities by addressing social determinants of health, enhancing access to care, and building capacity for advocacy and civic engagement. Before joining the foundation in 2020, Sheldon served in senior leadership positions with state-based policy and advocacy organizations, a rural health consulting firm, and both federal and state agencies. Sheldon earned a bachelor's degree from Cornell University and a master's degree in health policy and management from the Johns Hopkins University School of Public Health. He has served on numerous boards and commissions focused on enhancing health and healthcare. Thank you for being here, Sheldon. So, as you have heard, we have a robust and very well educated and traveled group of panelists today who are very well versed and experienced as it pertains to many health care and health related issues, specifically Medicaid. And so we're excited to hear from them today as we dive into this topic of Medicaid at risk and basically exploring the landscape further. With that being said, I will kick us off with our first question. And that question is, given the current sociopolitical climate and the potential Medicaid cuts that are being considered, what are the potential long-term economic consequences of reducing Medicaid funding for states, specifically Missouri, especially in terms of public health outcomes and healthcare costs? And Sheldon, would you like to kick us off with that?
Sure. Thank you, Robert. Thank you for those introductions. I think all of us probably have to write shorter versions of our bios to be read on these things. So, yeah. So thanks for that question. I think it's really important to look at Medicaid as both a health insurance program, as a health insurance program, a program that affects families' finances, and a program that affects the economies of local communities and states. And so I'm sure we're going to get into all the details through the course of this conversation, but just very briefly, the proposed cuts that are being talked about in Washington, D.C. right now will lead to millions and millions of people across the country losing their Medicaid coverage. We've estimated that here in Missouri, we'd be anywhere from about 100,000 to 170,000 people losing coverage. Most of those people will remain uninsured because they work in low-income, low-wage jobs that don't provide health insurance. It's the reason they're on Medicaid in the first place. And so not having that insurance will directly affect their access to healthcare services, their ability to receive treatment for any issues they might have. But more broadly than that, it puts their personal finances in a situation where they're going to have to be making choices. Do they pay for healthcare services? Do they pay for rent? Do they pay for healthcare services? Do they pay for food? And when those kinds of decisions have to be made, healthcare generally comes out on the short end unless somebody has a critical life-threatening need. And so it immediately creates financial hardships on families. Beyond that, because Medicaid is a big part of the payment that healthcare providers receive for providing services, losing Medicaid patients, losing the ability for those bills to be paid, places our providers at risk. And that's especially an issue in rural communities where providers are operating on very thin margins or perhaps losing money every year. And the loss of Medicaid funding will put the survival of a lot of those providers in jeopardy. And then finally, the last piece of this is Medicaid brings billions of dollars into the state of Missouri every year from the federal government. That money gets spent on healthcare services, and it then ripples through the economy. So when someone uses Medicaid to pay for a doctor's office visit, the doctor then used those funds to pay for staff and to buy equipment from local suppliers. And those local suppliers are then receiving that Medicaid funding indirectly. And that ripples through the economy. And the loss of an amount of money at the levels we're talking about is going to have profound influences on local economies here in Missouri, on the state economy, and I'll leave it to Amy to talk in more detail about the impacts on the state budget. But the ripple effects are going to be seen in communities all over the state, and so it's more than just a personal health care issue, which fundamentally it is, and that's really important, but it's bigger than that as well.
Thank you, Sheldon. Would any of our other panelists like to chime in on that question? Tim, Amy?
Yeah, I'll jump in. I would, Sheldon did a great overview, and I'll just accentuate a couple points, and then, I think it's first and foremost, I always put the person first, the people that are on Medicaid who will be affected. And as we sit here today, we don't know what exactly that number is going to be, but, the bill that they're considering is going to be profound and large in terms of the number of people that will be affected in Missouri. And of course, they're all on Medicaid, so they're all low-wage workers and, people that don't have a lot of money to kick around. So first and foremost, would be the people to be affected. But to add to what Sheldon said, we don't, I can't put a precise number on it, but we just have expanded Medicaid in this state, and we've added 350,000 people in the Medicaid program. And we know what a profound positive economic impact that has had on the state. Before the Medicaid expansion happened, we lost something like 10 rural hospitals in the state, and that spigot has stopped. I would predict that if we started, cutting, if we lost some people on Medicaid, we'd start losing some more rural hospitals. I think so. That's one thing, and so that's just to add to what Sheldon pointed out. And it's I always like to point this out as an economist. The dollars for a beneficiary, which leads to their health care, is a dollar of revenue to a provider. So if you're cutting the dollars to the recipient, you're also cutting the revenue to the providers, which means doctors, which means nurses, which means social workers, which means mental health workers. They're all going to be profoundly affected. And, the final thing I'll say, and we can dive into it further, we just know from decades of research that there are long-term profound health effects of being uninsured. So the numbers that Sheldon pointed out, almost all these people will end up being uninsured, and they'll delay their health care. They'll not use preventive care, and we know that leads to bad health outcomes and, even death. So I'll leave it there.
Thanks, Tim.
I would just add very briefly that I think, both Sheldon and Tim already said this very well, but to give this some additional context, some of the cuts in the federal bill come in the form of restricting how Missouri can raise money for Medicaid. And those restrictions put the entire Medicaid program at risk going forward for years to come, which also, it impacts areas of the budget that are not necessarily often thought about as Medicaid services, but things like mental health. The area agencies on aging use Medicaid funding to provide home delivered meals for people. There's education and in-school health services. There's all sorts of ways this funding really bolsters the state budget and the services that we can provide.
Thank you, Amy. And that's a great segue to the next question. You talked about so many different sectors that, that'll be affected because of the potential economic implications of the Medicaid cuts outside of the health effects. So the next question is, who are those populations that would be most affected by these Medicaid cuts? And specifically, what are the implications given existing racial, geographic, or disability-related health disparities? Earlene, I know that you've done extensive work with the Missouri Health Net in addition to the storytelling campaign. What are those populations and groups that you heard from, and how would they be affected?
Yeah, definitely our low income working families. Of course, those racial and ethnic minorities who already have a number of, comorbidities that need to be addressed. Definitely children, our seniors, individuals with disabilities, that's where individuals with disabilities get their care. When we look at children, more than 50% or close to 50% of children in the United States are covered by Medicaid. It covers a large portion of our children. And so these potential cuts impact that as well. And then when we look at our rural communities, especially here in Missouri, is very prevalent that many rural populations are traveling more than an hour for care because they don't have providers. We saw a number of rural hospitals close prior to Medicaid expansion, and that's just going to further exacerbate that for those communities, as well as lead to probably additional hospital closures and less providers as well.
Wow, thank you, Earlene. And based on what you just said, as you can see, it's going to affect a lot of different demographic groups and a lot of folks across Missouri. Would anyone else like to add on to that?
Well, if I could just add, and again, it's a moving target as of this moment. We think we know what's in the bill, but it could be different in the end. But I will say that the primary target of the current bill is work requirements, and and I would say the first order effect is that those will probably primarily hit the people in the expansion group, and that's what Sheldon's numbers have shown from Missouri Foundation for Health. But to Earlene's point and to what Amy mentioned earlier, to steal their thunder a little bit, all this will have a profound effect on the whole program. So if you're putting in a work requirement that's going to lead to people losing coverage, it's going to affect the whole household and the whole family, which could mean their kids. It could mean people that with disabilities. It could mean, their elders that they're caring for. So, think of this as not just the direct effect on the individuals, but just to your original point, Robert, the people on Medicaid expansion for decades, I can tell you, I've been doing research on this for 30 plus years. The people on Medicaid, are largely low income workers who do not have access to employer sponsored insurance because they're not offered it and they cannot afford it. So the vast majority of them are going to work, and they just need the Medicaid coverage because they can't get it otherwise. So this is how they will be affected. But I'll see if others want to add to that.
I just wanted to jump in because Tim makes an important point about work requirements, and that's where a lot of the debate around the bill is. And you hear a lot of rhetoric coming out of Washington about people should have to work to get these services. And I think it's important to make clear that most of the people who are on Medicaid are working. The problem with work requirements isn't that they force people to go to work. The problem with work requirements is that they create a series of hoops and red tape and administrative hassles that people have to go through to demonstrate that they either meet the requirement or meet an exemption. And a lot of people end up falling through the cracks. And so what we know about work requirements is that the vast majority of people who lose coverage are losing coverage not because they're not working. They're losing coverage because they can't document to the level that the government requires that they document their work hours. And so that's really important to consider. And then to go back earlier, I wanted to underline a couple of things that Earlene said, which I think are really important. Is one that, there's also this common kind of mythology that Medicaid is an urban inner city issue. And we know that as a proportion of the population, more rural people rely on Medicaid than urban people. And so it is really fundamental to the health and well-being of rural people and rural communities. And a lot of legislators who are thinking about these cuts are not understanding who it is it's going to be affected by the cuts. The second thing is that Earlene mentioned how many kids are covered by Medicaid. A very small proportion of the population that's covered by Medicaid are folks who are aged and disabled. but they are a very expensive population to take care of. And so about half of our Medicaid spending in Missouri are to folks who have disabilities or to folks who are aged. And you can't make cuts at the levels we're talking about without affecting the people that the money goes to. And that is largely people with disabilities and older folks. And again, so there's a lot of emphasis on, no, we're just aiming at people who need to get to work, and we're just aiming at people who otherwise don't deserve this care. People with disabilities rely on Medicaid as a lifesaver, and they are going to be fundamentally affected by these cuts.
If I can, I know we've kind of moved into the next question about Medicaid work requirements and the impact of that, and which I think is great. But I want to emphasize something here about, what Sheldon has already pointed out is that, 1 in 4 Missourians utilize Medicaid coverage for healthcare. That means that every family has somebody who is covered by Medicaid. Every family in this state is impacted. And all of us know that the basic flaw with work requirements is that all of us have periods of time during our lives where we can't work. We're going to be asking people to report monthly that they are working. And that just doesn't happen. Think about folks with cancer diagnoses who can't work during that treatment, people with mental health challenges who can't work until they're better. Folks who have a tragic accident, right, who cannot work during their treatment and recovery. These folks would lose health care at the very time they need it the most. So that will impact all of us.
Thank you, Amy, for giving those examples of how folks specifically would be impacted through the work requirements. And I appreciate all the panelists for their input on who would be affected, by the Medicaid cuts and the different things that we're seeing right now that are under consideration. Someone mentioned the healthcare infrastructure, and I think it was Sheldon, regarding nursing homes and our elderly population and other specific groups. Mental health services were also mentioned as being impacted through the Medicaid cuts that are being proposed. How are those providers in those different sectors preparing or responding to these potential cuts, or what would their response be if these cuts did actually become a reality?
So I'll jump in since you name checked me, Robert. I'll start, and I think I'll look to Tim and others to fill this in. So 2/3 of the people in nursing homes in Missouri are supported by the Medicaid program. So the very existence and survival of nursing homes depends on the Medicaid program. Cutting the Medicaid program is going to cause a lot of nursing homes to close. I mean, there just is no other way around that. That's the funding is too crucial to what they do. What are they doing to prepare? I think they're doing a lot of what we're trying to do, which is advocacy at the legislative level. But there's no real other way to prepare for this. A nursing home in particular doesn't have alternatives. Because the way we pay for long-term care in this country, unfortunately, is that most people spend all their assets and all their money until they become poor enough to become Medicaid eligible, and then Medicaid picks up the tab for them. And we are not proposing anything as part of this big budget bill that's going to address the other side of that problem, which is how we fund long-term care services. We're just looking at how we get rid of funding for long-term care services. I could talk about rural hospitals, but I'll hand that to Tim because that's something that he has studied for a long time. But rural communities are really reliant on Medicaid for their hospitals, and Tim could talk about that a little bit more.
Yeah, the rural hospitals, and I've been at several meetings on this recently, essentially, as I mentioned, 10 of them closed before Medicaid expansion. There's, depending on which numbers you look at, there's hundreds of them across the country that are at risk. And I will tell you that just on average, rural hospitals run negative margins or very, very close to zero. So if you just think about what we're talking about here, just at the margin, if you just take a few dollars out, which is what would happen with these cuts to Medicaid, some of them will close. And so they're, as Sheldon said, the first thing they're doing to prepare is trying to just educate the policymakers about what this means to rural communities, rural jobs, rural people. But I would also broaden that out to, so I think hospitals are, they're just reeling from the end of COVID and, trying to deal with workforce issues. Public health agencies are still dealing with that. And, maybe they were just starting to figure that out, but they've had some budget cuts lately. So, I think that's worth putting in the equation. So we're going to layer this on top of the budget cuts that have happened recently from Washington on public health agencies, on FQHCs. And so I would also throw FQHCs and rural health centers into the mix on this too, because, the Medicaid expansion helped them quite a bit. But I think whatever gains we've seen in Missouri will be reversed. Basically the numbers I've seen from CBO is we will reverse most of what we've gained in the last 10 years from the Affordable Care Act, if we believe the CBO numbers. The numbers will reverse 60 to 80%. That's how many people will lose in terms of the coverage gains that we've had. That's the magnitude of what we're talking about. So, the FQHCs, the rural hospitals, safety net hospitals in urban areas, it was really hard for them in 2013 and during COVID, and they probably just can't take this hit.
Yeah. And Tim, to your point, it's interesting that the cuts that you mentioned that are already happened, this would just layer on top of them. But yet some people think that it actually is contradictory to the cuts, that were already made. But in fact, I think most of us realize this would just be another layer and another further impact, and not actually a reverse of those cuts. We've seen some of the things that have come out with Elon and his remarks about the reconciliation bill being a reverse of the savings, quote unquote, that have been had through DOGE. But in fact, this would just be a further impact on a lot of the community health worker cuts and other things that we've seen that have already happened. So thank you for highlighting that. Would anyone else have any other comments regarding that question before we move on?
I would just point out two quick things. Mental health providers after Medicaid expansion were able to expand their services into rural areas and rural communities. As we, make these cuts, they're probably going to have to retrench, right? And so that really is going to have a significant impact in rural areas. The other piece about this is that, somebody in the questions has been talking or asking about how are we going to document any sort of exemption or that you are working. I think it's going to be really impossible for the Department of Social Services in Missouri to process the new requirements and the redeterminations because they are not able to do their cut work, appropriately. We've seen that over the last year and more, that people are losing coverage erroneously. Because even though they've submitted what they were supposed to, the Department of Social Services lost it, or they couldn't reach somebody in the call center to get help in order to find out what the department needed. So we will see people across every population, whether it's working adults, parents, kids, older adults, people with disabilities, all lose health care because the department is not going to be able to handle this.
If I could just jump in on that, Robert, and I know I'd like Earlene or others jump in, but I just want to accentuate what Amy just mentioned. We don't have to guess what's going to happen because we just went through the Medicaid unwinding. And then the Medicaid unwinding, we looked at the entire Medicaid population. And in the year that we did that, the 27% of people lost their coverage. And another 18% of people we don't know about because they never reported what happened to them. So, so we had a lot of people that got lost for the reasons that Amy said, through procedural reasons mostly, and they tried to submit the paperwork, it got lost, staffing issues. We're notoriously understaffed in the state. And I just want to just put people's heads around this. So every year we got to re-verify all the people on Medicaid. Now we're going to re-verify them twice if this bill goes through in its current form. And then we're going to do work requirements on top of that. So I don't know if I do that math on that, that means that we're going to be doing 2.6 million. Maybe you don't do the kids, but you do 2.6 million verifications. Then you do probably a significant number of those people, you're checking on their work requirements, and we don't have the staff to do what we already do. And if you're talking about 3 million plus touch points with the DSS, God help us all. Sorry for.
Yep. And Tim, to that point, when states have implemented work requirements under like Arkansas, Georgia, that has cost those states additional costs and administrative costs to implement those work requirements. So that is going to be an additional burden on the states, right? You're cutting federal support, and now the states themselves then have to implement these work requirements, like you said, and come up with an efficient system that will cost them more money to do that. So, and we've already seen that it costs money for them to do that. So that's a great point.
Yeah, I would just also add, Robert, and then we can move to the next question is, the Department of Social Services, which runs the Medicaid program, requested more than 200 additional staff during this last legislative session, which is as much an admission that they can't get their work done as just looking at the data. And the legislature did not approve those positions. And so they're going to be moving into this without any additional staff to do, as Tim said, twice the amount of work.
Sheldon, thank you for highlighting that, the difficulties and even, staffing, to get the applications and process folks for receiving Medicaid. That's a great segue into a question I have. And Earlene, if you wouldn't mind kicking us off with this question, given your, work in training and providing technical assistance on the Mo Health Net application, how would local governments, nonprofits, and other entities, grassroots organizations, what would their role be in mitigating the impacts of Medicaid cuts and even helping folks navigate the potential challenges that we're mentioning with these reconsiderations and reconciliations that we're mentioning?
Yeah, we definitely would have to stand in the gap for those consumers who need this program with education just on what do you need to do. We also need to be those advocates at the table with the stakeholders explaining all the issues. We're well versed, of course, in the many issues and implications that may occur should we have these cuts, but we as the advocates have to be there in the community and sharing those lived experiences with those stakeholders who have the decisions in their hands around these cuts. We often can identify as advocates what the problems are, but sometimes it can be seen as we're just complaining. But if we can bring those lived experiences to the table, it humanizes the recipients and lets them know how they're being impacted. And how, these cuts and things as simple as work requirement, it creates a lot of gaps in care. It also takes away a lot of the gains we've made here in Missouri with Medicaid expansion. We also did postpartum extension. We now can get doula care with Medicaid. Those two things go directly to Missouri's mortality rate, which is very poor for women who are giving birth as well as their infant. But I think that's the best thing we can do is be the educators, gather fellow advocates, as well as stand in a gap, help our constituents get their applications and get their documentation in, and then be at those tables to identify what's working well, what's not working well.
Thank you, Earlene. And I love that you mentioned humanize. We focus so much on the dollars. We've been having a lot of economic conversation and dollars, and those are important considerations, but at the heart of it, it's the human aspect, right? We all are humans. We all are impacted, and we all need to be thinking about that when we think about these decisions. While they're economic in nature, they do impact our humanity at the heart of it. So thank you for mentioning that. Would anyone else like to chime in? And before you do that, actually, I just want to remind folks, there is a chat if you have any questions. We will be getting to those questions here shortly. So if you do have any questions that have come up, I see some already coming in. feel free to add those questions to the chat, and we will get to those here shortly when we have a Q&A period for our panelists to address the questions that you all have. But with that being said, did anyone want to add to what local governments, nonprofits, and other grassroots organizations, how they play a role in mitigating the impacts of these potential cuts?
I mean, I think Earlene did a great job, so I don't want to add very much, but I just want to accentuate the point made earlier that this would be layered on top of what they were already facing, those organizations. So, we can't just sort of say, oh, they can handle this, because there have been a lot of cuts to those organizations. We have heroic organizations in the state that are doing things, but they're already taking some recent hits, and we may be moving into a recession. So I just want to point that out.
And to add, I mean, I think it's important to think about, this is a classic situation where you can take money out of the Medicaid budget and on paper save that funding, but then you have to make it up somewhere else. And so before the Affordable Care Act, before Medicaid expansion, for example, states had specific line items in their budget to fund mental health services. The fact that people were able to get Medicaid coverage to pay for those services largely took away the need for states to put that funding into their budgets. We are now creating a situation where we are going back in time to before we had Medicaid expansion and before we had all these people on the program, to having just a lot more gaps in the system. And if we're not offering people comprehensive coverage that will pay for whatever their specific needs are, we're either going to have to find other funding to pay for those specific needs, or those needs will go unmet. And that, again, as all of us have said, puts a lot of pressure on the providers who are going to have people walking into their offices without an ability to pay. And some of them will be in a position to provide services anyway, and some of them will not.
Going back to the question of what people can do, I think, Robert, that's what you were asking about too, is that, in addition to sharing stories, your personal stories of your family members, concrete examples of times that you have not been able to work because of, mental health challenges, illnesses, accidents, injuries, and that, you would have lost your healthcare coverage under these rules at the very time that you needed it the most. And that means that people are not going to be able to work. They're not going to be able to get better. They're not going to be covered. Somebody with a mental health issue is not going to be able to get the treatment that they need to become able to work, right? They're not going to be able to get the medications that they need to become stable enough to work. And we need our lawmakers to understand that. So I would strongly encourage everybody to be reaching out to their federal lawmakers, particularly our senators. Senator Hawley and Senator Schmidt need to hear from Missourians, because this is moving very quickly. We only have a window of a couple of weeks here to really impact how this ends up, the final version.
Yeah, thank you, Amy. And that's a great point about storytelling. And we are actually going to have some announcement around that later on. We're excited to announce that. But thank you for highlighting, because as you mentioned, Josh Hawley, our senator here, one of our senators here in Missouri, he posted an op-ed in the New York Times, and it centered on a story, right, that he heard from someone in Missouri, a mother, regarding her challenges. And that was a powerful story that really impacted his perspective, as he mentioned, on why he is such a staunch defense for these Medicaid and against the cuts. And so with that being said, does anyone else want to add in on how storytelling from, Medicaid recipients, community members can influence policy and decisions, and what types of stories folks can tell and how they can tell those stories?
I'm well known as being a data wonk, so I love numbers better than anybody. But I will just tell you that it's my firm belief that the best way to persuade is to pair a data point with a real story. And so if you can say, like I always like to say, 40% this, 10,000 that, 10% cut there, then if I can just say, Robert Jones is that person and this is their situation, or if there's a rural person named, you know, Susie or whatever, that, boy, that's what persuades legislators. And if you can really tell them that X percent or X thousand people in their district, in their zip code, are the ones affected, I'll just speak for Amy and Shelton and Earlene and others that, I think that's what's kind of, in my opinion, kind of pushing the pendulum a little bit the other direction, because I think there's been numbers that have been produced about the numbers of people in certain zip codes. And then, as you mentioned, Robert, if you can put a name behind that and a face, it's pretty hard to turn away from a name and a face.
I agree with Tim. We had some experience here at Legal Services of getting a new process halted just from sharing a client story with the media when they were doing third-party verification. I think it was with LexisNexis, and people were falling off of Medicaid because LexisNexis was pulling inaccurate information and closing coverage, saying people lived in different states. And we directly shared a client stories who had that experience, and that process was immediately halted. I also think now it's especially important to share those client stories for those recipients who have done everything correctly, turned in their paperwork, who have complied with deadlines, and they still lost their coverage due to the failure of Family Support Division to have capacity to process the paperwork. We've seen that several times here at Legal Services, and it just kind of goes to the point. If you add additional administrative barriers, people are going to have gaps in coverage, which can be detrimental to their health outcomes.
Yeah, and thank you for that. And what I hear folks saying is that, and Risa, I want to give you say a great quote. Would you mind sharing what you say about numbers and stories all the time? And people?
I always say no numbers without people and no people without numbers. To your point, Tim, about pairing, like it's one thing to see a chart and a graph, but when you actually hear how that actually impacts an individual, a family, a health center, a hospital, a community, then it really takes on a different tone. And I will add to that the stories need to be relevant to the folks where they are. So meeting folks where they are. If you know this is the district that you represent, what does this mean in my district? If we're talking about advocacy, here's what the numbers actually mean. And here's your neighbor who can share with you what the actual impact is of the outcome of this legislation that we're talking about, as if it's just numbers and not actually impacting lives and economies in real time.
Robert, if I can just jump in and give an example that has been in the media the last couple of days about the power of storytelling. It's not a healthcare story, but a lot of folks have seen this story of a woman in Kennett, Missouri, down in the Boot Heel, who is an immigrant and is beloved in the community. She's worked in the local pancake house for the last 25 years, and people absolutely love her. And this is a community that voted heavily for President Trump. Well, she was picked up by immigration authorities and folks in the community who thought, oh yeah, I don't like the idea of undocumented immigrants in my community, but I love Carol. I love this woman who works here, who I know, who I see every day. And the community banded together a group of folks who maybe ideologically didn't necessarily agree with the folks who think that more immigrants should be in the country, but they got together and they raised the stink, and she has been released by the immigration authorities. And so just a great example about how humanizing something and connecting it to a person changes this abstract conversation that folks have to something that is much more real.
And I would say that people, like many of you on this webinar today, are changing that conversation. This bill has changed dramatically from where it started in the House to what passed the House. And we still have Senator Hawley, who is raising concerns about what remains in the bill. So you're making a difference.
Thank you. Thank you, everyone, for chiming in. And I think we've heard the power of stories, the power of people and data, and how those things are intimately connected. And so with that being said, we want to open it up for our question and answer period. I know we've had a lot of questions rolling in the chat, and we appreciate that participation. Thank you for your questions. What we're going to do is we're going to address the questions that have already been placed in the chat, and my colleague Asia Owens will help me navigate those questions. And Asia will read those questions out loud or paraphrase the questions for the panelists. And then if we have time, we will allow folks to raise their hand, and we will allow you to potentially ask a question that way orally if you would prefer. Risa, did you have something you wanted to say?
No, I was looking at the gateway to better health question, but I will defer.
Oh, sorry. I saw your finger go up.
Oh, no, sorry. I'm reading with my hand.
No worries. All right. With that being said, Asia, would you like to voice the first question from our audience members?
And our panelists have been so active and already addressing some, but I'll just start with the first one I see from Megan Fields. Would you be able to please provide more detail and examples of what might keep a consumer from being able to document their work and income? And then also, would there be any stipulations regarding a situation where a consumer was unable to work due to a life-threatening illness, like a doctor's excuse, and help them keep their coverage?
Well, we may have already addressed this to some extent, but I would, having experienced the Mo Health Net portal directly for family member, the process that you would have to do, and we don't have a work requirement now, but I can imagine it would be somewhat the same. You would have to go through some process of uploading some documents, of answering some questions, and whatever that process is, it breaks down sometimes. Documents get lost, and you get asked questions that and you have to remember to do it in the right amount of time. And these people are working hard, and it's just a burden. I have to just say this. I'm sorry, I just have to do it. They have the data. This is just perplexing to me. These people they have incomes and they have payroll taxes. So I'm not even really sure why we even need to do documentation to upload things in the portal, but I know they will ask to do that because they won't even trust that data. But I'll just stop there.
It would also say that some people, like a significant number of people, they wouldn't necessarily have electronic data for.
Right.
If you think about farm workers, people in construction, gig workers, the gig economy, the Uber Eats, all of that stuff isn't automatically uploaded or isn't every month. Even the tourism industry in Lake of the Ozarks, Branson, people's incomes fluctuate, as we all know, and they don't necessarily, if they're seasonal employment, they're not working every month. How do you prove monthly that you have income? When you're going to lose a lot of people because of this.
Yeah. And I'll add that, you need to have an internet connection. You need to have broadband to be able to upload these documents. That is not something that's available to a lot of people, especially in our rural communities again. You need to be able to understand what the requirements are. I mean, one of the things we learned in the Arkansas experience that Robert mentioned earlier was that most people didn't even know they were required to document that they were working, and then they were dropped off coverage. And so there's just a lot of issues with all of this. And I know that a lot of people are putting comments in the chat about their experience. The state is horrendously far behind on processing the work that they need to do now. And it just is difficult to imagine how they take on all these additional tasks and do it effectively and in a timely way.
I think it's also important to highlight the language barriers for many of the recipients. Even though we document on applications that the particular language that someone may speak, they do not receive notices in their language. And so that makes it more difficult for the immigrant population. And then again, to emphasize what everyone's already said, the state just can't keep up. You can do everything right, and your information can just sit there. It's also important to highlight like that auto close feature. If a case is in touch, doesn't mean that you didn't comply. It just means no one actually touched the system to say that they saw the documentation you submitted. And so again, you're just causing more people to go without care they need because their coverage is closed.
Well, if I could just add this real quick to Earlene's excellent point. When I was chair of the Mental Health Net Oversight Committee and we lost a bunch of people, a lot of it was because of that language barrier. A lot of it was because they got a letter in the mail. And, first of all, did they have the right address? That didn't happen a lot of time because people move a lot. Number two, that they might have opened the letter and said, oh, I'm still on Medicaid, or thank you very much. Because these letters, I've read them, they may as well be in another language, and they're written in English. And, they basically say, people say, oh, I think I'm still on Medicaid. And I don't know what I'm supposed to do because they're not written in a very straightforward way. And so a lot of people just don't know what the heck to do with these letters.
Yeah, and I'll add that one of the ways to get assistance on all this is to call the 800 number that the state runs, the call center. And here in Missouri, our call center data, our metrics are the worst in the country. So folks wait on calls for an average of about an hour before their call is answered. More than half of people drop off before they ever talk to somebody. A lot of people are just randomly cut off, even though they're trying to wait. And, I want to make sure I mention, we've spent a lot of time talking about all the difficulties that the state has in processing this information. This is not a knock on the state workers. I mean, they are working as hard as they can possibly work. They work in agencies that have been underfunded by the state legislature for decades. They're working with computer equipment that is 20 and 30 years old. And the systems to do it efficiently just don't exist. And so this is not in any way a knock on state employees. This is a knock on the situation that they're put in to do a job that is going to become much more difficult.
Thank you, Sheldon. And that's a great point. We really appreciate all of our, state workers. We know that there have been some state workers who've been impacted and lost their jobs, right? So we want to thank them as well and acknowledge them for their work and recognize that the system is what is being overworked and not performing as well as it needs to, not our workers here at the state. And I will add one more thing before we get to our question. I think we forget a lot of times too, again, that Medicaid doesn't exist in a vacuum, right? We just talked about all these different sectors that are affected. Well, let's talk about education, right? We talk about people getting things in the mail. There is a big literacy problem in America, right? And healthcare is one of those topics that it's really hard sometimes for people to understand. So even if they get the mail in the right way and they get the letter, do they really understand everything? We talked about even for our, legal immigrants and the language barrier. What about folks who do speak English as their primary language? They still have trouble reading. We've seen that the rate of our literacy rates have gotten worse over the last 10 years in our country. And so that's a big thing to consider as well, is that there are a lot of folks who just struggle to understand the information, even if they do get the information. And that will just become another barrier to them getting access to healthcare if these things are put in place, these other, barriers that we mentioned. With that being said, Asia, could you please lead us into our next question?
Okay. Why would they not look at possibly starting an adult program that is more like the CHIP program? Adults who fall within a certain poverty limit have to pay a monthly premium.
So I would say that if we built a program like that for adults, it would have to go up to the same income level that CHIP does, because they're very different. The Children's Health Insurance Program currently goes up to 300% of poverty in Missouri. You can qualify. And so those premiums, and we know those premiums are still a barrier because Missouri has the highest premiums in the nation for the Children's Health Insurance Program applied to the lowest level of income that's allowed. So people at 150% of poverty and above are required to pay premiums for their kids. And those folks fall through the cracks too often. But so I would caution us that that type of program can't replace what we currently have with Medicaid and Medicaid expansion.
And I just can't resist to mention that, in a sense, we already have such a program. It's called the Marketplaces, sometimes called Obamacare, and it goes up to 400% of poverty, and there are graduated subsidies, which were enhanced in the previous administration, and those enhanced subsidies are scheduled to end at the end of the year. So the CBO projects nationwide that 5 million people will lose their coverage because when they lose their subsidy, to Amy's point, at the lower end at about, 138% of poverty, 100 below that are Medicaid, and then they start going to the marketplace. Those premiums are maybe pretty affordable, but maybe not, depending on your age. Then with those enhanced subsidies, it's been pretty affordable. But if you take those away, those people are going to start dropping that coverage. So anyways, I'll stop there because it looked like Sheldon wanted to jump in.
Yeah, I was just going to jump in and bring us back a little bit to what I think is part of the point of this session today is that, wonderful. People are coming up with great ideas and saying, why don't we do this? Why don't we do that? I'll remind everybody, we can do anything we want if we can build a movement to get our legislators to do it. If we had the will, we can afford to have universal coverage for everybody in this country. What we have never been able to do is build the political will to get there. And so a program like CHIP or any other program are all possible and may all be improvements, but we have to do the storytelling and the power building and the working on the ground to build that base to get us there. And that's something we just have not yet been successful with.
Great point. Great point. The power of the people. The power of the people. I appreciate that, Sheldon. Asia, could you please give us our next question?
Yes. Could you discuss what happens if and when federal Medicaid cuts happen and the fact that Missouri is one of 3 states that requires participation in Medicaid coverage in the Constitution?
Yeah, great question. And I think we covered some of what happens with the cuts, the effect on facilities and FQHCs and providers. But I would definitely appreciate if our panelists could highlight how Missouri is different and unique in the sense of our initiative petition process that we have and how that would be impacted if these cuts happen and what that would look like.
So I would say very quickly, briefly, Medicaid expansion is in the Constitution, yes, but it does not preclude us from moving the work requirements forward, right? Like Medicaid expansion would still exist. The problem is that work requirements are going to be applied to everybody, and then there are going to be categories of exemptions, right? So kids are exempt, and seniors are exempt, and people with disabilities are exempt. But, as we know, the real problem is going to be like all of the cuts, people losing healthcare because they can't document that they should have an exemption or that they are working.
And I would just add to Amy's excellent point, quite literally, the Medicaid expansion would theoretically not be at risk because it's in the Constitution, but you can't take blood from a turnip. So if you start taking some of the other cuts that are in this bill, where are they going to find them? And it's important to keep in mind, I don't want to go too far on this, but it's important to just put a marker on this. There are optional and there are mandatory aspects of Medicaid. And so if the state has, and we know we are fiscally challenged in this state, and if they have to cover the Medicaid expansion population, I'm glad they do, then they may start looking at some of the other elements of the Medicaid program, which are those optional services, which are probably, I'll just list a couple of them: dental, mental health, some other things. And so we may start seeing some, even though the federal government said, we didn't cut a particular service, the state might have to end up doing that because where are they going to find the money?
Yeah, great points, everyone. Thank you for highlighting that. And if anyone has a follow-up question regarding that, if you need more clarity around initiative petition and Medicaid expansion and how that all fits into our Constitution here in Missouri, please feel free to follow up that in the chat if you need more clarification. With that being said, Asia, our next question.
All right, and I think this is one Risa probably wanted to speak to. Historically, the Gateway to Better Health program in the St. Louis City and County assisted uninsured residents in those areas. Is there a chance of bringing that program back?
Yeah, Risa, take it away, as this is intertwined deeply in the history of CHCM.
Yeah, so the regional health, CHCM, formerly the Regional Health Commission, shepherded the Gateway to Better Health program. And it was initially designed, it was a federal waiver, and it was initially designed just to be a stopgap once Medicaid or once the ACA was passed. It was intended to provide a bridge for adults, uninsured adults who otherwise would not have had access to coverage, and to give us kind of a ramp to understand what it would look like and what it means to get folks into this coverage. When we passed the constitutional amendment, the Medicaid Expansion Amendment 2, August 4th, 2020, that was when we began the process now of unwinding the Gateway to Better Health, because that, again, was the purpose, right? In that, the folks who were on it were then transitioned, the majority of them were transitioned on to Medicaid. And so there wasn't, right, with Medicaid expansion, the same need for the program because there was a coverage option. And that's what allowed us to be able to have the state plan amendment. We had conversations around what does it look like if there's another waiver that needs to take place or what happened. And the folks around this call and around this table also have a lot of expertise and wisdom around the cost benefits analysis of that, like what's the good and the bad, and where our advocacy efforts can land. So I don't have, we don't know yet, because to Tim's point about knowing exactly who's going to be impacted and where the bill actually lands, I think that will then inform us of where the advocacy needs to be and what the most appropriate approaches are to ensure that those who are not able to access the coverage that is designed for them to access are able to receive care. So I know that's a convoluted answer. I apologize for that being a convoluted answer, but saying that it existed because of Medicaid expansion, that's why it's sunset. And so now we're trying to be really thoughtful and strategic about what are the ways that we're able to ensure that those who are at risk, most at risk of losing coverage, we're creating plans that do not have unintended consequences for the advocacy and for the efforts we have to cover the entire state. So more to come on that, depending on how things shake out and how the conversations continue to evolve.
Thank you. No, that's great. That was a great historical context. And I'll just add something to highlight two things that you said. You know, that program was funded through an 1115 waiver, which is a federally funded means of providing funds to states to do these types of, planning projects or, temporary projects. Well, we're talking about cuts at the federal government. What are the chances that the federal government would approve another 1115 waiver to do something like that? And then additionally, you mentioned a state plan amendment. If the state of Missouri was to potentially implement something like that, again, that would be in light of the additional burden that the system would currently have in funding Medicaid, because as it was mentioned, it's a part of our Constitution, Medicaid expansion. So it would just be an additional cost is what I'm trying to say. If the state was to fund it, the two options are that you highlighted. If the state funded it and covered it, additional cost to the state on top of the cost that they would also incur from the potential cuts. And if we go back to the federal government through 1115 waiver, what are the chances and likelihood that they would continue to fund something like that in the future? Probably very low, right? So I think that was great, what you just mentioned, and I just wanted to highlight that.
Can I also say that part of my concern here is we already know that Medicaid is currently struggling and it's going to struggle more with this, but this bill also includes additional requirements related to the SNAP Nutritional Assistance Program that is going to just magnify all of the impacts. Under SNAP, they would expand work requirements too, and shift costs to the state of at least $400 million per year. And Missouri, as it's already been said, really can't afford that, which means people are going to lose their SNAP assistance as well.
Okay. And I know we probably have a little less than 10 minutes left, and I know we have some great questions. So I guess as we move through, if we can try to address the rest of these questions, but as quickly as possible. The next question is, how can we protect and preserve Medicaid from misuse, especially in light of federal funding cuts? It is crucial to ensure that eligible individuals do not lose access to the essential services they depend on for their health and well-being. How can we safeguard the integrity of the program and help those who genuinely need it and receive it for the support that they deserve?
And I would say, I mean, that's been a big talking point on the federal bill, is that some of our congressional leaders are talking about their desire to weed out fraud and abuse, right? Well, I would say that the vast majority of people covered by Medicaid are not fraud. You know, they all need access to health care. Fraud that exists in Medicaid is usually on the provider side. And we already have some tools in place where, for instance, somebody may overbill or bill twice for Medicaid, and just so that the provider gets more income. We already have tools in place to deal with that. So this bill is not about fraud and abuse. This is really about cutting Medicaid, which is critical for our entire state.
And, I'll also just add that, we know what we need to do to cut down on fraud and abuse. And that is largely fund programs that specifically look at that. And it means we need to have enough staff working on the program. And those staff need to have up-to-date tools at their disposal. And at the same time we talk about fraud and abuse, we also don't provide those tools to fight it. But I also want to underline what Amy said, is that the vast majority of people on Medicaid are eligible for Medicaid and meet the requirements of the program. And I think a lot of the talking points we're hearing out of Washington get to folks who they're defining as who the program was originally intended for, or the people who really deserve it. And the people who deserve Medicaid are the people who meet the eligibility requirements of the laws that Congress has passed. And those are the people who are in the program. If Congress doesn't like the fact that all those people are in the program, they can go about trying to change that. But trying to label them as people who don't deserve it is not really addressing what we're really trying to do here.
And Sheldon, I think that kind of goes into this next question. From Craig Smith, he says there are some senators that are not supporting the reconciliation bill because it doesn't cut enough. What is the likelihood that we can protect Medicaid when the pressure is to cut even more? They're responding to the stories by saying that these are the people that we actually want to protect. The argument is that they're only saving money that is wasted on those who shouldn't be getting Medicaid, so that those who should be getting Medicaid continue to get the help that they deserve. How do we respond to address this to the legislators?
If I could jump into this one, because this one I feel really passionate about, is like, I think this is really a false narrative, because, what they're setting up is this dichotomy of there's these, able-bodied folks, is the quote they're using, and then there's deserving people on Medicaid. And that's really a false narrative, because the folks that are so-called able-bodied that are in the expansion group, they are on there. I said this earlier, I want to just accentuate the point. They're on this program because they are not offered insurance, they're working, they're not offered insurance, or they're not able to afford it. So they're doing the right thing. They're not, and so these are people, largely 90% or so, that are doing the right thing. They're maybe caring for a child, caring for a disabled person. There's several questions on the chat about that. So to characterize them as sort of not deserving is really false, I think. And we just need to keep pushing back against that. Certainly children, disabled, pregnant women, elderly, these are all needy populations as well, but we cannot let that narrative go further. I'm sorry to jump in and just.
Well, that's perfect. I'm sorry.
No, go ahead, Amy.
I was just going to add to what you said, Tim, and I totally agree. I feel passionately about this too. The being qualified as disabled in Medicaid, all of you probably know this, but to get a disability qualification is really difficult. You have to be determined as permanently and totally disabled to fall into that specific category. And it can take 2 years to go through that process to have the federal government determine that you are disabled. So we have what that means is we have a lot of people with mental health needs, challenges, who just went through the process with Medicaid expansion because it was easier, and that often mental health is not considered a permanent disability. So, it's hard to prove that for people. So these are the folks who are really at risk. Are they not deserving? I think they are. And I also think there's lots of evidence that in our community that if you help people with their mental health needs up front, if you get them prescription medication, if they have access to ongoing counseling and stuff, you end up with people who can thrive and participate in their communities just like everybody else. So, and if you don't invest in people, you end up with much more expensive, catastrophic things occurring.
Thank you. Oh, go ahead. Does someone else want to say something?
I was just going to give another example of the kind of person who might fall through the cracks, and that as currently written, the bill allows states to look before someone is even put onto the Medicaid rolls. They have to have been working for a month, and states can actually add more months to that. Well, suppose you lose your job and it takes you 2 months to find a new job. In that interim period, that's what Medicaid is for. It's a safety net. And we are now trying to create a program that would say to folks, you lose your job, you are on your own. Medicaid is not going to be there to support you, because if you lost your job, you can't document that you were working in the previous month.
It's good.
This clearly should have been 2 hours. And I wouldn't want to add any extra stress to the panelists, but I'm wondering if there's a way with some of the other questions, if we could maybe, if you all shared your emails with him, we can, or some way we can find a way to capture these other questions and get our panelists to answer them, because there's some really great questions.
And Asia, I think that's a great point. And I think we can do that. And we can help facilitate that at CHM through what Reese is going to mention, which I'm excited about, through some things we're doing around storytelling. So with that, thank you all for your questions. Thank you, panelists, for your great insights and for answering the questions. Like Asia said, you've been active in the chat while multitasking, answering questions, staying involved in the conversation. So we really appreciate it. And with that being said, I would like to turn it back over to our CEO at Community Health Commission of Missouri, Risa Rollins, to close us out.
Awesome. Thank you so much. I really appreciate this conversation, and thank all of you for joining us today and for the work that each of you are doing just to ensure Medicaid remains not just a program, but a promise, because we talked about how it's so much more for individuals, for families, for our providers, for our communities, for our entire state. So right now, our Senate is deliberating budget reconciliation legislation. We're having the conversation right now that could bring deep and devastating cuts to Medicaid. And these aren't just policy shifts. These are decisions that affect people and their real lives every day. That affects all of us in the great state of Missouri, depending on what part of the state you're from. We see the power of advocacy, not just in strategy meetings and policy memos. I was seeing some in the chat, and it's easy to get frustrated and discouraged because it feels like sometimes you're banging your head against a brick wall. But Amy mentioned, Sheldon mentioned, Tim, your voice matters, and the work that you're doing and the advocacy that you're doing, it matters, because we're seeing a shift in the conversations. We're seeing with our senators, Hawley, coming out and having op-eds in the New York Times and telling stories about our neighbors in Missouri and why this is so critically important. So I urge you to not get tired, to continue in this fight with us. We are committed to being in the fight with you. And that's why we are joining whenever the call is put out to go up to the Capitol and do a press conference, or to send a letter, or to call a legislator, or to go and meet in person. Whatever your capacity and your access is, we invite you to join and to continue in the conversation, because you don't have to do it together. We're alone. We're in this together. I know firsthand what it means to have to make those choices that Sheldon was talking about earlier in his opening comments, about having to choose between, okay, am I going to get this medication, or I have rent to pay? I know what it means to have Medicaid. So it hits different when you've lived that actual experience. And it's not just theoretical, but it becomes really real. And so that's why we have decided that whatever tools we have in our hands, whatever relationships we're going to use. And so we're launching, as Robert mentioned, a storytelling campaign to tell stories, right? I am a storyteller at heart. And so, I said, that's what I have. I use what I have. And so telling my story to talk about why it matters, because I was working 3 jobs and still couldn't access healthcare. And that's the story of a lot of people across the state. And so you might have a story, or you might know someone who has a story. And so we invite you to continue to share those alongside with us, so that we can put the data with the numbers to really tell a compelling story about how our neighbors, our partners, work with the FQHCs on a regular basis. They are such a critical backbone to the infrastructure of our communities, financially, health-wise. Folks being healthy and being able to go to work, we need our health centers, we need our hospital systems in rural areas, in urban cores, to be able to be present. They can't do this without having the significant impact of Medicaid on their budgets and on their bottom lines. So, call to action. Don't get tired. Don't give up. You may need to take a break. I'm here for self-care. MSW here. I support it. Take a break, but come back and join us, and know that you're not fighting this alone. Think about where your best, I'm a preacher's kid, y'all, so I'm sorry, forgive me for a minute. But I always think about the story of Moses and the question, what's in your hand? Whatever you have, whatever your resource is, if we put all of our rows and piles of coins together, I truly am hopeful enough to believe that we can continue to make a difference. It may not be tomorrow. The road is long and hard sometimes, but I believe that we can do it together. So my request for you see in the chat that there is some information around Medicaid stories. Please share broadly and widely, so that we can continue to inundate all of our policymakers, all of our leaders, all of our, as they're making the decisions around why it matters and for whom it matters. And that's the answer is all of it. And I ask you to please take a moment to complete the event survey, because your feedback helps us understand what questions we need to ask, what conversations we need to bring, how we need to convene in the room to continue to fight, because this is our fight, and we will not back down, because our health is too important and it matters too much. So again, thank you for being here. You can tell I'm excited because I talk really fast when I'm excited, but thank you again for being here. And let's keep raising our voices, building community, and defending Medicaid together, because our lives truly depend on it.
Thank you so much, Risa, for that impassioned call to action, and for highlighting the things that we've heard today, the stories, the power of our stories, and how we can continue to raise our voices up to advocate. As Sheldon mentioned, we have the power to really see the things that we want to see by speaking out to our legislators. And so what we're doing here at the Community Health Commission, what Risa said is, I just have it on the screen, is that we are doing a storytelling campaign to really tell these stories. And so if you fill out the link in the chat, or you can just copy it from the screen if you want to take a picture on your phone and do it later, that's completely fine. Please share your stories with us, and we would love to hear from you and how we can amplify your voice and take your stories and really get them into the hands of our legislators, the folks who are making these decisions and representing us, representing you in Washington and on the state level. Also, as Risa mentioned, I just want to reiterate the survey that helps us is in the chat. There's a link to the survey. Asia, if you could just post it again so we can get it in there again for folks to see it. Please complete the survey. It lets us know how we impacted you today and what we could do better, if there's something we could do better. So with that being said, I just want to thank again the staff at Brown School at WashU for their partnership in this event. Thank you to all of our panelists, Earlene, Amy, Tim, Sheldon, for making time. Also, Stephanie, thank you for your work and the rest of your staff at Brown School for your collaboration and help in making this possible. And I want to give a big shout out to Asia for all of her work in helping to put this together and spreading the word. Asia, tremendous job. Thank you for all you do on the local level to really advocate for our communities. So with that being said, thank you all for attending. We look forward to staying connected with you. Enjoy the rest of your day. Be safe and be well. Thank you.